Okay, and thank you everyone for joining in this last session. I think this is going to be a fascinating case. We kind of took a different tack on this one because we were talking about challenging cases and what people could do in situations where the individual didn't seem to be responding. But now we find that a lot of programs are doing what they call kind of autopsies, social autopsies on cases where they've lost the person, and sometimes it's through death, and sometimes it's through just terminating them and trying to figure out what could they have done. This session focuses on a very sad case of a graduate who died very shortly after graduation. And so I'm going to turn this over to Dr. Mee-Lee, who can kind of present some of the background, and we'd welcome some of your thoughts, because I think that this is a very, it's a case that probably is familiar to many of you, but it's also extremely sad and extremely difficult, I'm sure, for the families and the team. So Dr. Mee-Lee, do you want to start the session?
Thanks very much, Carolyn. And yes, so as Carolyn was talking, you can see on the slide there that there's learning opportunities in any situation that doesn't go well. And we think of the team that I think in this case worked so hard. And as we go through the case, I think you'll see how they worked quite diligently in trying to address the multiple kinds of issues. And we'll also, though, point out, and I've put it in the slides, you'll see as I go through, I've highlighted in yellow things which are more prompts for me to make some comments about, and that might raise some principles that apply not just to this case as we kind of do a social autopsy on it, but also alert us to think about other challenging cases. We've had 3 challenging cases in this series. The first one was a drug court case, the second a family court case, and then this one a veterans court case. So that's a nice array of situations, and we're grateful to the team who got together the detail for this case. At the last minute, and we appreciate their work, not only on getting this case to us, but also the work that they did diligently with this particular veteran. I want to just remind everybody, as Monica said, we really welcome your participation. This is the last in our series, and we've really tried to open up the conversation about what can drug court teams think and expect and see from treatment provider teams, and in reverse, what do treatment provider teams need to expect from drug court teams, because it really is an important communication and collaboration effort if we're going to reach the kinds of outcomes we all want. So I would just encourage you that if you have any questions or comments or disagreements, that use the chat feature, or if you're connected by phone or through the microphone on your computer, that use the raise hand feature. We'd love to have some interaction. So let's go through this case, and the person who prepared this case for us, I highlighted, I think, an important quote from them that said, in the context of this challenging case, that it was very important both for the program integrity perspective of making sure that the Veterans Court program and the way it's structured has some integrity, but also from the awareness of addiction as a disease. And as I say, I wanted the community to be aware that addiction is a fatal disease, and it's not an easy path to recovery. I mean, I think that's a very accurate statement that sometimes gets lost when we're sort of mandating people to treatment, and we kind of think that if we mandate people to treatment, somehow that will result automatically in a good result because of the pressure of the court and the mandates that the person is under. But this quote, I think, speaks nicely to the fact that we're dealing with a deadly disease, and as true in this particular veteran's case, and that there are ups and downs, not just in terms of substance use and flare-ups, but also many other multi-dimensional factors that you'll see as we go through the case. And then the quote goes on to say, putting an aftercare program in place is our top priority. I felt our local newspaper article was extremely well done, and you'll see some quotes to that in the case as we go along. So in a way, the focus on this review of this case is to look at what might have been some areas that could have been included in the plan, and this would be most important in the collaboration with the treatment team and the court team. How did people work as hard as they could? Because I really got the sense that the team put a lot of effort into helping this person. And it raises also, in the ASAM criteria, we talk about a category of programs co-occurring capable, meaning the co-occurring addiction and mental health issues, so that programs need to be capable of addressing addiction and mental health issues. We talk about co-occurring enhanced, meaning that a person may be unstable in both addiction and mental health problems, and so you need a team that is cross-trained to handle unstable addiction and mental health. And then we talk in the ASAM criteria in this latest edition about complexity-capable programs, meaning that increasingly we're dealing with people who are complex, not just that they have addiction, but they have many other life issues going on. And I think you'll see as we review this particular veteran's case that the complexity added, I think, stresses to the progress through treatment and to what the team had to do. So here's some of the key information. This was a 47-year-old male veteran who has been estranged from his children in a different state and has very few family ties. Now, you know, that's a clue when you think of addiction as an illness. It's not unusual. I mean, it's not exclusive to addiction, but it's a clue that whenever I hear about a person being estranged from their family and their children, that is a good differential diagnosis to think of, is that this is somebody with addiction whose devastation of addiction on the person's life, as well as their significant others, children and family and partners, often leads to estrangement. And that just speaks to, again, we're dealing with, in that first sentence, I'm thinking, here's a person who sounds like they have severe addiction. And then the criminal charges are clearly drug-related charges, and you can see span clonopin, a benzodiazepine, hydrocodone, an opiate, and methamphetamine, a stimulant. So he's been using multiple drugs and got into trouble with that legally, with illegal behavior, distribution of dangerous drugs. And again, you can have somebody who distributes drugs or is dealing who may be just a criminal, a business person gone bad, and they're not necessarily using their own inventory of drugs, and that person really isn't eligible for addiction treatment. That person just needs to take the consequences of their criminal offending behavior if they don't have themselves the disease of addiction. In this case, though, I think this is a person who both was distributing drugs and, though, also was addicted himself. 5 years probation, and if he completes Veterans Court, his probation, would be eligible for probation discharge when he completed drug court. He is particularly hooked on methamphetamine and marijuana. And then a clue here again that under mental health, a depressed mood. Now, of course, depressed mood doesn't mean you have major depression and a co-occurring mental disorder. But you'll see as we go through, there are other clues that this is a person who it's more than just a depressed mood because of the situation he finds him in. There are mental health issues, which makes, in this case, the importance of co-occurring capability, or maybe even co-occurring enhanced work, if the mental health issues become more unstable. Here's an example again where unemployed, he was able to obtain some successful employment eventually and a supportive work environment, and so he was doing well as he went through drug court in terms of employment. The reason I highlighted employment is that when we start thinking about the ASAM criteria dimensions, you'll see, and I'm just going to jump ahead of those to remind you about these 6 dimensions. You'll see that really when we think about treatment, we should be considering all these dimensions, and employment issues would come under dimension 6, recovery environment. The depressed mood would come under dimension 3, emotional, behavioral, cognitive issues. And he's using and continue to use, and any relapses would come obviously under dimension 5, but also initially if he was intoxicated or needing withdrawal management for any of the drugs he was using, like methamphetamine or hydrocodone and so forth. So I guess what I'm saying is that as we go through the case and you see various aspects that adds to the complexity of this veteran, one of the ways to think about that is to identify those issues under the 6 dimensions. Now, from the court team, that's not your responsibility in treatment to be thinking about that, but just to recognize that when we're dealing with somebody who has many different housing, employment, relationship issues going on, that's a clue that we're going to need to work very closely together with treatment, because this is somebody who is not just a matter of struggling with substance use, they're really struggling with many other key features. Housing, again, would come under dimension 6, recovery environment. He was homeless when he entered the Veterans Court, but he did, through VA and HUD assistance, eventually get his own apartment. So some nice work was done. Here's again some of the things that added to his complexity. No driver's license or identifying immigration paperwork. He is Vietnamese, and you can see that he was really needing a lot of help to just get through some of the bureaucracy and to get some identifying papers. Now, in treatment, I highlighted the 6-week inpatient treatment part because one of the issues that you know from the ASAM criteria is that we talk about an individualized treatment length of stay. And I'm not sure whether the 6-week was because that's what the treatment program was designed to be, a 6-week program, or whether his severity was such that he needed 6 weeks in the whole time. But when you look at 6 weeks in inpatient treatment, then 18 months in Veterans Affairs, Veterans Administration outpatient treatment, one of the questions I would raise about that is, was that in a sort of flexible continuum of care where he was able to be perhaps stabilized in an inpatient setting, but then as he got stable, to give him a chance at testing out some of those skills of whether he was not now having cravings to use, or whether he was practicing some skills about getting involved with more healthy relationships. You'll see as we go along, he didn't have good assertiveness skills. And what you would have hoped that in that inpatient stay, not only would they have been working on housing and employment skills and his depressed mood, but also if he had problems with asserting himself and too easily fell into counterproductive relationships, that would be something that would be worked on, because that would have been assessed in the 6 dimensions, and that he wouldn't just be in 6-week inpatient program and then kind of move to outpatient, that you'd want to have a more gradual back and forth, or what I've talked about is putting him on the psychological treadmill. In other words, as soon as somebody starts looking stable in a more structured environment, in treatment, we want to try to give him a chance to test out what looks like good stability and see if he really is as stable as he thinks. So what I would be wanting to know, we don't have the details about this, is that during that 6-week stay, did he have a number of passes when he was able to go to outpatient? Was he able to be mixing with some of his relationships that we may actually have recommended he changed, but he might not have been ready to change them straight away? So you actually want him to test out before he's fully discharged from an inpatient and structured and safe setting. You want him to test out how solid is his stability, that he can actually cope with cravings to use out there, or deal with boundaries in terms of relationships, or choose the right kind of people to hang out with, or to develop a better positive support recovery system. You want people to do that not just once they're discharged or transferred from an inpatient setting, but overlapping with that, so that we can really nip in the bud if it's clear that somebody is not as strong as they look. And they look strong because they're in a structured, safe environment. He did have a mentor, but you notice that he had some relapses from alcohol after 2 months post the inpatient treatment. And this is what I was meaning. Now, it's not unusual for people to have a flare-up and to use. So that's not saying the inpatient wasn't effective, but I would like to have seen that before he was discharged, he wasn't just kept structured there and safe, and then when he got out into a looser, less structured environment, that's when he had a flare-up with alcohol. And then it says there that he was identified, the licensed counselor identified loneliness and the holidays as a trigger. Well, we kind of had the clue of that in the first sentence, when it was he was estranged from his children and no family ties. So again, to what degree did the team make sure that when he was not in the structure of an inpatient setting, that he had the kind of support system that when, you know, and ideally if he was active in AA, for example, or Narcotics Anonymous, they're the perfect people to be with, that when everybody else is celebrating on holidays, that there's a safe, sober group of people that he can socialize with. So some of the things I would have been interested in knowing is that before that relapse 2 months after post-inpatient treatment, how solid was his Dimension 6 recovery environment? How solid was he in having friends who didn't use? Was he active in 12-step or other mutual help groups? Because if he was, that would help protect him some during the loneliness of the holidays. Now, that doesn't mean that he would have been perfect and nothing would have happened. People can still have relapses even when they have a good support system. If some crisis comes up, or if their cravings to use become overwhelming, that can happen even when people have a fairly good support system. But in his case, knowing that he's estranged from his family, knowing that he is somewhat a non-assertive person, then an important part of the treatment plan would have been how strong is his recovery environment and what has been done to work with him to develop a much more supportive environment. And then he also, alcohol relationship with significant others ended 13 months after entering Veterans Court. So that was another stress because of, again, relationship issues. And we already have a clue that he's estranged from his family, lonely, and now a relationship with a significant other ends, and that's a setup for him as well. These kinds of issues come under the designation of recovery environment in Dimension 6 and Dimension 3, emotional behavioral cognitive issues, because what was being done for the loss of the relationship. And then some of the other struggles that were identified well by the team, I think, are these interpersonal relationship boundary issues, and that he acknowledged having difficulty staying away from people who use drugs. So that's what I mean about when he was in the inpatient and looked fairly stable, we want to actually give him a chance to get destabilized. Not that we want it to blow up, but we want him to see what it's like being out there a bit on his own and who he gravitates to, which friends he gets back in touch with, who he hangs out with. And if we notice that he's drawn to people who are actively using still, that says something about the quality or lack of quality of his level of stability, so that you can almost anticipate something could blow up. In the case management section, there was a lot done to really help him in many different areas, hundreds of hours of case management. So this was a diligent team that worked hard with really addressing many of these housing and employment and other issues. The record indicated that he did not receive moral recognition therapy, even though that has some good evidence in terms of cognitive behavioral therapy approach. But I highlighted that, and in fact, this veteran didn't receive it because it wasn't in place in this particular court until January of 2016, so fairly recently. And this particular veteran was getting close to the end of his Veterans Court stay and close to graduating, so he wasn't put into that late in the game. But the reason I highlighted it is to make sure that we don't keep still thinking that addiction is just a behavior problem and a behavioral disorder needing cognitive behavioral therapy. There is a tendency to think, well, if we do MRT or CBT or, a variety of other behavioral treatments, that's where the evidence base is sort of focused on. And yes, there have been those kinds of services available, those kinds of models, and we're not saying they're not helpful. But if we just do cognitive behavioral methods and don't take into account all these other complexity issues, then we're thinking that it's just predominantly a behavior problem, when in his case, we've already recognized loneliness, difficulty with boundaries, difficulty not working and collaborating with people who are using, estranged from his family, mental health issues as well. Graduation, I highlighted because, yes, we graduate people from Veterans Court when they've demonstrated a certain level of function and being able to move through the phases and have negative drug screens for a certain period of time and all those kinds of things. And that's understandable, but remember a central learning point of this was the importance of an aftercare plan. And in treatment language, while it is appropriate in a drug court or veterans court or specialty court terminology to talk about graduation from the program and then aftercare, when you look at it from another lens as addiction as a deadly disease, as we found out in this case in particular, and then you think about the ASAM criteria perspective of a continuum of care of disease management levels, where a person moves through them in a flexible way depending on their severity and their function and their progress, then really the mentality, especially in severe addiction clients, is not one of graduation and aftercare, but of continuums of care with ongoing care, which is just as important as this initial phase of 18 months in a Veterans Court program. So while we may continue to use the word graduation, I guess what I'm encouraging us to think about is not thinking of it as graduation and then people just go to a much more stepped down aftercare program as if we kind of fixed them in the 18 months in the program as they went through the phases, and then aftercare is kind of just some additional supports as an aftercare to the main treatment. I think that mentality moves away from what I think we should be talking about in terms of chronic disease management of addiction as a continuum of levels of care where really you can't have aftercare in a continuum of care, it's just care. Now, the client himself was very appreciative of what the team does. Here's a quote. It says, "It took the team to help get me through all of the things that he went through." And he says, "I thought I was too far gone." So the team did good work in restoring with him a sense of hope and of hanging in with him and helping him to get through a lot of real world problems like employment and living situation. But that progress, as we know, didn't hold, and that's why we're looking at the case. Because he did do well. He got a place to live, he got a good job, he was sober, he was managing any mental health conditions you can see there that were involved. And so here's somebody who looked like they were doing well and was doing well, and the team worked very hard with him, and yet the reality that addiction is a deadly disease that has relapses and flare-ups is just normal. So he did graduate from Veterans Court and had his case dismissed, but then we learned some new information after graduation that 2 to 3 weeks after graduating, he relapsed on methamphetamine, and most likely his dimension 2 physical health problems were related to the stimulants creating a heart attack. He had multiple surgeries and intensive care unit stay, so got quite sick. 4 days after his hospital discharge, he had another heart attack from a methamphetamine overdose. So here again, he gets stabilized in these inpatient and acute care settings. But then we'd want to know is what's the quality of his ongoing care? To what degree was he kind of stabilized in an acute situation, but then people weren't thinking enough about chronic disease management to make sure that he's linked to ongoing services. So he was actually with 2 known drug dealers at the time that he used methamphetamine and died from a heart attack, probably from the stimulant effect of methamphetamine. And then the note here about aftercare, that there was no formal aftercare program, and it's not like the team forgot about it. They did recommend, it seems, and talk about it, because the client indicated an intention to continue addiction treatment at the VA and was seeking the assistance of his case manager to help him to do that. But then another set of sad circumstances was that his VA treatment provider was injured and out of the office for a month after the veteran graduated. So he wasn't really well linked. I just took a sip of water. It wasn't well linked to continuing care. And this is a reminder again that if we remember that addiction is a deadly disease that needs a flexible continuum of care, that we have to start moving away from the mentality of graduation and aftercare, where aftercare too often has been in the past an afterthought, or where we've referred people when we need to increasingly think about linking people to services. Now, that's not just fancy terminology. It really is saying that referral to continuing care services or referral to aftercare is not good enough for anybody, and certainly wasn't good enough for this person. And the example I give about linkage versus referral is that if you go to a relatively, doesn't have to be a 5-star hotel, and ask them where is the restaurant, they don't tell you to sort of walk down the hallway and turn left at the fake palm tree and then turn right at the gift store and then take you, tell you to keep walking towards the restaurant. They actually take you there. Even CVS and the pharmacy, I went in and asked them for some Q-tips, and I said, what aisle is it on? Expecting them just to tell me the number, and I could find the name of the number of the aisle. No, the person actually walked me to where they were. That is linking, and how much more important it is with people with the disease of addiction that we link people to continuing care services, not refer them. When a hotel and a drugstore and CVS has more awareness of linking people to what they need than just telling them and referring them. So this team worked very, very hard with this person, and you'll see a bit more about some of the things that they did. But as was mentioned at the very outset, one of the things that's very important to realize: addiction is a deadly disease, that recovery is not a smooth path, and that continuing care after court graduation is critical. So this was some more additional information that was provided by the team. The primary issue was immigration. The participant was born in Vietnam, but he lived there until shortly before he entered the Navy. So when he came to court, he didn't have any identifying documents. He couldn't get his military records without identification. He could not get a driver's license without a birth certificate or military ID card. So as the writer says here, it was a never-ending circle of bureaucracy where the team worked very hard to help him with resolving unpaid traffic fines, transportation issues. He needed help with financial counseling, dental services, housing applications, supplemental nutritional assistance, and employment. And he had not filed any taxes or registered with Social Security. So here's somebody who sort of fits in many ways what we're talking about, complexity capable, where we're really dealing with people with a complex mix of issues. It's not just substance use. And why do we have to deal with that? Well, because they all interact and affect the person's likelihood of a flare-up of their substance use, because they get under stress. They hang out with people who they're familiar with, who are not necessarily the ones who are going to have recovery in mind. And then you get a flare-up where we're now facing not only a loss of the gains that he made, but in this case, even death. So it was recognized that he was not an assertive individual. That, again, should alert you there's a Dimension 3 issue. We're going to have a specific treatment plan for that. It isn't just hoping that that will all change as he gets more and more sober. So he was not an assertive person, which the writer felt that contributed to his difficulties with boundaries. We should have worked on his assertiveness with him, because this was a defining characteristic. Again, if we were looking at all of the 6 ASAM dimensions, when you got to Dimension 3, emotional, behavioral, cognitive, these are the kinds of things that would be listed in that particular dimension. And if you list problems in that dimension, you've got to do something about it as well. So it prompts the treatment plan. Now, the participant shares that he feels stronger about his boundaries. So this was some of the progress he was making with the good work that the team did. He relates no longer with them, feeling like he doesn't have anything in common with them, because he, was starting to be in recovery. He shared that he is in bed by 10, so he started to have a healthier lifestyle, and something that he didn't do when his disease was active. Now, again, a little while after, a couple of months later, in June, we received information that he was in a dating relationship with a known methamphetamine user. So again, this flashes the importance of continuous assessment to look at, is anything changing on the 6 dimensions? And in this case, that relationship with a known methamphetamine user would be a dimension 6 issue, a recovery environment issue. And so we wouldn't want to just note that that's happening. We would say this is a potential crisis for somebody who is estranged from his family, who's not very assertive, who has trouble saying no to people. Here he is in relationship with an active user, and this is a sitting duck in terms of something blowing up. So it says then we required that relationship end, but a reminder that these things are treatment issues where we have to work with the person's emotional, behavioral, cognitive issues to help him understand how the relationships he finds himself drifting into often are counterproductive. And it isn't a matter of the court or the judge just mandating you will now not be with that relationship, as if then the person is fully engaged in wanting to make that life change. Yes, we can mandate that, but if the person themselves isn't struggling with that issue of loneliness, of non-assertiveness, to be able to set limits for people who are using around him, if he doesn't have the confidence to feel like he can make friends who perhaps are more functional, not using, he drifts back to somebody who he feels comfortable with. And this is an issue then of not just, well, I mandate you not to be in that relationship, but it's a matter of collaborating with the treatment program and saying, this is a potential crisis. We know that this person's lonely, estranged, depressed, has trouble with boundaries. We know that he, by his own admission, he has trouble being assertive. What are you doing, treatment provider, to really work on this in a way that doesn't set him up for using again, and that is working with him in a holistic way to work on every aspect that might be some vulnerability to getting a good outcome. So in August 2015, he reports, the client reports that he needs to keep working on boundaries. So he's been made aware that this is an issue. October, he reported loneliness and articulated the importance of boundaries. So this is good documentation that we're recognizing the problems. What I would be asking is what is being done about those problems. And this is where the court team can hold the treatment team accountable for, we don't just want to know this is the way he is. We knew that from day one when he was estranged from his family and his children. And we knew from other relapses that have happened in the course of things that he is vulnerable to drifting back with people to feel comfortable. In his last treatment session before graduation, he stated, James shared that he will graduate from Veterans Court. He shared that he has gained a lot, and he shared that he feels that the service provided him helped him, and I'm sure that they did. People worked very hard. And he wants to continue in group once a week with case management. Now, again, this raises the issue is, did we just say, well, that's good, you want to continue, I'm glad that you want to do that, we certainly think you should do that. To what degree did we actually link him? To what degree did we make that a critical part of the treatment plan, where before he graduates even, that he has already seen somebody and been linked with somebody and forming a relationship, so that there's a smooth transition from graduation from Veterans Court to the critical issues of ongoing, not just support, but actual treatment for the things that we know make him vulnerable to relapses. And the point about this is that if you go through and say, well, what's the individualized treatment plan based on an assessment of the 6 dimensions, we could identify a number of these areas that have been referenced, but then not just to identify them, but to say, what is our treatment plan? Treatment provider, what is your treatment plan to make sure this doesn't blow up? Because as we then find out, it actually did blow up, and there were clues going through his case that these relationship problems is a major issue, and the team recognized that by talking about boundaries. My point is just to not make sure that we note it, and then certainly try, and not just to mandate him not to be in those good relationships, but to really say, treatment provider, to what degree is this because he might have a co-occurring mental disorder or major depression, that he's not able to be so assertive and be so proactive in building a positive support recovery system? What do we have to do to make sure he's actually going to mental health, to mutual help groups like 12-step groups, so that in the holidays when he's lonely, that he could be triggered to use? In other words, we don't just want to say, oh, he's complying and he's checked off that he's going to meetings. We want to know what's the quality of his involvement. Does he have people who he can hang out with when things are going badly? All right. I think we have some questions or comments. Do we, Monica? Should we take those?
We do have a comment. One attendee says, I believe a missing component of consideration and a critical element of his case management is his ethnicity, because his cultural values around family affected his self-worth. His ethnicity affected his means of asserting his point of view. So
yes, that's an excellent point.
Mm-hmm.
Yeah, but a good emphasis that it's not just an emotional behavioral cognitive issue. This could very much be part of cultural issues, where assertiveness in this way and going along with the group is something that would be culturally consistent, perhaps. And you know, we talk about individual responsibility and individual assertiveness, but in the culture of a Vietnamese person, that's going to need extra special attention, given the vulnerability to actually relapse when he's in the wrong company. So yes, cultural competence, and that's when we talk about complexity capability, we're really talking about cultural, language, in his case, great difficulties with identification, and all of those things were an added burden to him. Are there any other comments or questions or disagreements from anybody, or similarities of this case with anything that you've dealt with? Because we'd like to open it up as much as possible to other kinds of comments.
We don't have any at this time. If anyone would like to submit any comments or questions, just a reminder to use the Q&A panel at the bottom right of your screen. And I will interrupt you, Dr. Mee-Lee, if we get anything.
Okay, great. So the original comment here in presenting the case was the importance of an aftercare program and the recognition that addiction doesn't follow a smooth path. And so I would just emphasize that by reminding us that if we focus on the treatment of the addiction as the drug court or the veterans court or the family court as being just one initial piece in a person's total recovery plan, that the team did a good piece of work in terms of dealing with the complexity of multiple issues: housing, money, employment, recognizing some of his vulnerabilities, which either come from personality issues and or cultural issues. the team did a good job of identifying those things, but then where we could improve the plan, and this is where the collaboration with the treatment provider comes, is that in those 2 relapses that happened, were they carefully assessed as to what happened? And if they were assessed and identified, as it says there, loneliness and holidays, what was the corrective treatment plan after that? So the court team would be saying, okay, he relapsed, we're not just interested in sanctioning him. What are you going to do, treatment provider, to make sure that this is less likely to happen if he has a much more positive support system? So if I were to look at his record after these 2 relapses, and especially the first one that was 9 months after entering Veterans Court, which was sort of about halfway through, if I didn't see a more robust emphasis on what he was doing with AA or NA, and I don't just mean I mandate you now to go to more meetings. It's not about mandating him to show up at more meetings. It's about having the treatment provider work with him to say, well, how are we going to deal with your loneliness? And what are there other Vietnamese people that are in recovery you could be with? And being very specific in the individualized treatment plan about addressing those vulnerabilities. And then the other issue, as I mentioned, in terms of as we get towards the end of the initial piece of work in a drug or specialty court, that really is just an initial phase of this person's recovery. We want to really make sure that there's a very robust overlapping of continuing care services, because as we indicated here, the client was willing and interested in doing that. What I'm not as confident about, not having seen the whole record or talked to the team, is that robust work was done in actually linking him to those services. So ideally, before a person even, quote, graduates from a specialty court, the idea would be to have them already be linked and be starting to form a relationship with an ongoing counselor or a treatment program. And so in this case, did he actually have somebody who he was going to see? Did he have an appointment? Had he already had a couple of sessions with somebody? Did he already know what the date was of what he was going to do, or was it just left to, well, make sure you contact them? The other issue here was his tendency, not just about assertiveness, but to be drawn to people who were still actively using, because it may have been his difficulty in making new friends, so he just drifted towards people who were more comfortable to be with, albeit people who were still using. So again, a more robust treatment plan. So if we were looking at this chart, what I would be interested in seeing in terms of the serial treatment plans, especially after the relapses, and especially after the fact of building a relationship with this person who was an active drug user, would I be able to look at the progress notes and the treatment plan and see that those specific vulnerabilities were being addressed in a very aggressive way? And so the court team would not be expected to make those decisions, but they would be expected to hold the treatment provider accountable to show me what you're doing for this particular veteran with these particular set of vulnerabilities to do an individualized treatment plan. And not just to think that if we mandate the person to stay away from that relationship, that's taking care of it. That really is not something that's going to work if the treatment provider isn't working robustly with those emotional and cultural kinds of issues. Well, I don't know, Carolyn, if you're there, if you have any general comments about not just this case, but other things that have come up in terms of this critical treatment issues series, because we are nearing the end of it and we've covered a lot of different things. And we want this to be, I think, a continuing conversation as we keep trying to improve the services that we do together, court team and treatment team.
Well, I think that we will, we're going to have another session at the NADCP conference, I think it's June 1st, a 3-hour session on challenging cases, and we welcome anyone to send some in, and we've got some we've collected, because I think it's really important to be able to brainstorm with others approaches in some of these issues. And we're finding that this process of really looking at what could have been done, or what were the factors, or even what lessons do we learn from situations where, unfortunately, we lose the person through a variety of means, are just really important. And that's, part of the medical process, isn't it, Dr. Mee-Lee, where you kind of do kind of an analysis of what was good and what wasn't. So.
Right. So, yes, and in this case, unfortunately, he died soon after graduating, but we can learn from his situation. So a question I have for you, Carolyn, because I'm not as familiar, to what degree do all of the specialty courts have a good overlapping with continuing care, or quotes aftercare? I mean, I guess I like continuing care because it's really continuing the care that was started in the specialty court. Is that a common continuing process, or are we just getting more started around aftercare programs?
Well, I think your earlier approach had been to have aftercare as literally aftercare. When you graduate, you're referred to some, aftercare mechanism. But I think increasingly we realize it's a chronic disease, and that the linkage into the aftercare recovery, continuing care resources need to be there from the start. I know a lot of programs that have alumni activities get those started in the start. So I think this is, extremely important to have that continuing care component built in right at the start. So people are linked into the recovery community and are not, in fact, there's some drug courts that got away from the word graduation because it is inconsistent with the chronic disease nature of it. And it's interesting that the International Association of Drug Court Professionals that has 13 principles, the 10 that we have, the 10 key components, and then 13 others, the 3 others, one of them is aftercare, and the other one is case management. And I forgot what the third one was, but they recognize that early on.
Just to interrupt real quickly, we do have a question from an attendee who says, how can you build in continuing care? Most clients want to move on after completion of primary care.
Yes. Well, if a person is not interested in continuing care, that would alert me to my worry that they're just complying doing time in the drug court or the specialty court program. And if you have a client who kind of gives the impression like, well, I've done my time, I've graduated, I've gone through the phases, I mean, just sort of leave me alone, that would be an alert, which if the drug court team saw somebody like that, the first thing they should be saying to the treatment provider is, wow, has this person just been doing time in your treatment and really hasn't grasped the seriousness of the disease that they have? And so that's why we've talked earlier that if somebody, even early on in treatment, in the first month of a specialty court, it's looking like they're just sitting there drifting through, that should be addressed sooner while you have the leverage of the court, not to have somebody get towards 12 months or 18 months, and then they kind of think, whoopee, I'm graduating, I can get away from these people, I'm not interested in aftercare. If that's their attitude, then something's not happened in the whole 12 months to engage that person in the realization that they have a serious disease. So that sort of attitude should be picked up sooner in treatment and worked with, not because it's bad, but because that's normal in addiction. But it shouldn't be happening towards the end of a specialty court period, because then that's telling you that the person's just kind of been doing their time, waiting to get out from under people's grip. We have another comment, Monica?
Yes, we do. It says, in some cultures, the ultimate punishment is banishment from the community. His isolation and loss of family seem to weigh on his emotional health, and time does not help heal this. It makes it worse. Restoring or connecting family is worth the effort.
Yep, I would agree with that, and that again comes under Dimension 6 recovery environment, where we would want to take specific steps in the treatment plan to do that. And if he was interested in that, that would be tied in with what we've talked before about creating incentives that are meaningful to the individual client, rather than generic incentives like a gift card or a meal certificate or something. But that again would be an issue of individualized treatment with this particular veteran, to see, is that something he would like us to really help him with, and that could be an incentive for ongoing recovery as well. But in answer to the question of the other comment about what do we do when people want to just they're not necessarily interested in continuing care, I just can't emphasize enough that if you identify that kind of attitude, we want to identify that earlier on in treatment, when we still have leverage and a chance to work with that readiness to change issue, and to make sure that they don't see the specialty court as a process of just going through the motions for a set amount of time, because then when they come to, quotes, graduation, they're thinking, I'm fixed and I don't want to do anything more. That's a perfect setup for another offense and substance relapse, and then the cycle goes back and forth. We should be able to pick up, treatment providers should be able to pick up that attitude way sooner than towards the end of somebody's phase in a drug court process. And if they haven't, those are the kinds of things that we have to be opening up the conversation with, to make sure we're identifying people who just are drifting through much sooner rather than later, so we have a chance to do treatment with that. Well, I see we're at the end of our time, and I thank everybody who've participated in this series. And as you know, if you've missed any or want to review any, they are available on YouTube, and we invite you to keep the conversation going as we work together to improve the outcomes of the people we serve. So thank you very much.
Great. Thank you very much, Dr. Mee-Lee, for all of the sessions in this series. And thank you, everyone, for attending. All right. That's it.
Bye-bye.